In 2019, the Centers for Medicare and Medicaid, or CMS, will begin tying Medicare reimbursement to a series of value-based measures, including quality, efficient use of electronic medical records, improvement projects, and cost. The first three have been used by CMS in the past. The fourth is entirely new. Thus, UF Health, as an institution, we need to understand how we can begin to meet this measure. CMS is going to calculate costs by looking at the procedure cost for any individual procedure, comparing it to a national benchmark that is adjusted for patient complexity. This sort of adjustment is called risk adjustment. Risk adjustment is based upon how sick a patient is. The sicker a patient, the more complex that patient is to care for, the more that care is expected to cost, and the more it costs for an insurance company to insure that patient. So this risk adjustment, or risk scoring for an individual patient, has the potential to increase how much it looks like our patients cost, and thus allow us to meet this cost metric. What kind of reimbursement do we get? So Medicare plans to reimburse physicians, or increase their reimbursement by up to 9% if that physician or practice is several standard deviations above the national benchmark, and decrease Medicare reimbursement by up to 9% if they are several standard deviations below the benchmark. For UF Health, this would potentially mean up to $8 million annual increase in revenue from Medicare, and up to $8 million annual decrease in revenue from Medicare. This is in addition to the various pay-for-performance and cost-sharing programs that Medicaid plans have. So we have some contracts that potentially will pay us more if we meet certain quality metrics, one of those being cost. So there's a huge financial incentive as an institution to attempt to meet these measures. So how do we capture risk scores? Risk scores are captured by a provider on any visit with a patient, where they put down a diagnosis code, or an ICD-10 code, on a claim or bill that they send to CMS. CMS then records that patient and that diagnosis. However, CMS only holds these records for 1 year. So after a year, that's wiped away, and the patient has no diagnosis, no diseases at all, according to CMS. Now, these diagnosis codes can be used for any disease. So you use them for the flu or for tuberculosis, right? Things you can potentially recover from. However, the diagnosis codes useful for risk scoring include ones that are for chronic diseases only, so kidney disease, or amputations, right? These sort of diseases that don't generally get better and are going to be with the patient throughout their lives. How these ICD-10 codes are combined can increase the risk score or even decrease the risk score. So combining them effectively is key to maximizing your risk score. What are some of the challenges we face in order to begin using this sort of risk scoring process? Well, physicians already sort of notice some diagnosis. They record some patient diagnosis. However, they don't often do it effectively, and they don't often do it when it's not the point of the visit. So for instance, someone coming in to see a doctor because they have the flu, that doctor doesn't always think to record that they also have diabetes. However, if that patient hasn't been seen in a year, they have no risk score, even though they do have diabetes. And so one of the biggest challenges is getting physicians to actually record these diagnosis codes. Unfortunately, doctors are not reimbursed for recording diagnosis codes, only when they record procedures. So if a doctor does a procedure and records it, they get paid. If they record a diagnosis code, they get nothing. So we need to financially incentivize doctors in order to potentially get them to try to do this. One way might be to emphasize the financial incentives that are gained on the back end through these cost-saving programs and through this additional Medicare reimbursement and perhaps tie some physician incentives to their use of HCC codes or diagnosis codes. Another way we could do this is try to make it as easy as possible for the doctors. So we could create quick lists within the electronic medical record that make selecting the correct risk score, the correct diagnosis code, very simple. We could involve nurses in order to get them to take some of the diagnosis early and let the doctor know, so it's less work on the doctor's part. We could create reminders to remind a doctor in order to capture these codes every single year. Two of the best ways to do this are we're going to have to focus on physician incentives, getting them to actually do the work, and making it easy for them to do the work. These risk scoring, it's the future of healthcare. Healthcare is moving towards increasing quality and decreasing costs. Risk score is one way to show that your actual cost meets the complexity of the patients that you see every day. Thank you.